Good evening. My name is Dr. David Doman, and welcome to another edition of House Call. Our topic tonight is geriatric medicine, care for the elderly. My guest tonight is Dr. Suresh Gupta, a specialist in geriatric medicine, care for the elderly. Dr. Gupta, welcome to House Call.
A pleasure meeting you. Thank you for inviting me.
My pleasure. Briefly, tell our viewers about your professional background and how you came to specialize in geriatric medicine.
Well, I'm a practicing physician in the United States. After doing my residency training, I began my career in '86. Which is what 32 years ago I have been practicing in Montgomery County. My main specialty focus is internal medicine and geriatrics, which I practice in Silver Spring, Montgomery County. And of course, I do inpatient care medicine at Holy Cross Hospital, which is nearby, which I love, my inpatient acute care.
Very nice. So briefly, explain to our viewers what exactly is geriatric medicine?
Well, when I came, it's a country with beautiful people, and I saw the geriatric elderly population with their special needs, special attention they need. Somehow internal medicine, I'm more focused on elderly population, their needs, their issues, their social health issues, economic issues, housing issues are much different. Everybody's on 29 medications. You have to sort out what they are on, what they should not be on. They're getting different medication for different specialties they go to. So it sort of became very interesting to me to sort that out.
Good for you. I'm sure you find it very rewarding to help these older patients.
At the end of the day, it's very gratifying.
Yeah.
When I do see and admit my patients at Holy Cross, which is inpatient, I find more interesting because these people elderly people come very sick. Mm-hmm. They're extremely sick. And turns out they have some bizarre infection, some colon infection, some urinary tract infection, they call alternate sensorium. Turns out they say complication of a lot of polypharmacy, or they have some infection.
And if I can interject, by polypharmacy for our viewers, you mean multiple medications?
Polypharmacy is multiple medication. They go to orthopedic, they get 5 pills. They go to gastroenterology, they get another 5 pills. They go to neurology, they get another 5 pills. So they really don't know what they are on, and that complicates the matter worse because a lot of them duplicacy occurs. And a person like me, when they sit down at my table with all this medication, say, okay, let us stop this, add this, stop this. So this sort of is very intriguing and very challenging at times.
So let's view some of the individual challenges about caring for our senior citizen patients. You mentioned several times multiple medications. Share with our viewers what you're challenged with when you have somebody with multiple medications. You mentioned duplication as one thing. And what about drug interactions?
Many a times, these multiple different medications are duplicates. They're on 2 beta blockers. They're on 3 blood thinners, but nobody doesn't know what he's on. So that really complicates matters. And as a result, they get into trouble because of polypharmacy or multiple medications. As we know, as we all grow older, we lose our mental faculties, we lose our arthritic joint pain, but at the same time we also lose our kidney function. Mm-hmm. So the excretion of through the liver or the kidney, it just goes down with the aging. So the dosing of the medication, that also has to be adjusted to the kidney dose. So that I find again very interesting. That is a common problem these elderly people have, this polypharmacy business.
And what about do you ever find that one drug can interfere with the benefits of another drug?
Very common. These days, luckily we have nice electronic data system in which the computer alerts you. You can give them amlodipine with 40 milligram of simvastatin, for example.
Simvastatin for high cholesterol.
High cholesterol. It's okay to give atorvastatin, but amlodipine and simvastatin does not go along. So there are lots of medications like that, which will warn you that don't do this. But it's because of the elderly people, multiple physicians they see of different specialty, that problem still exists pretty rapidly, because computer can only pick up what you feed to the computer. So sorting out on exam table with medication, the bag they bring, is very interesting.
You mentioned with age, some people may experience silent declining in their kidney function or liver function. So does that mean for our viewers at home, if they've been on medicines for many years and they have not recently checked their liver function or kidney function, they should have it rechecked just to make sure that the dosages of the medicines should not be adjusted?
Very true. In my patients who are elderly, geriatric people with multiple medication they take, I think it is mandatory we check their basic blood tests. For example, we call CBC, complete blood count. We call a CMP, a panel which tells me the liver function, kidney function, electrolytes, and sodium, etc. So it is must that I must do these routine blood tests, if possible 3 months, at least every 6 months they should be done. Because that will, when the kidney function goes down, I need to step back on blood pressure pill, for example, ACE inhibitor, like lisinopril. If they have some ARB, which is losartan.
These are medicines for blood pressure.
They're medicine for blood pressure or the heart or thing, because they're all kidney renally excreted. Yeah. So I need to be adjusted them. Otherwise, it makes the kidney worse. Instead of helping the kidney, it hurts the kidney.
Now, if somebody who's a senior citizen is taking these medicines and unbeknownst to them, their kidney function or liver function has deteriorated with aging, that means their prior safe standard dose may no longer be safe because they're no longer being properly cleared by the kidney or the liver. So the next question for our viewers is, okay, if the prior safe doses are no longer safe, what kind of side effects can they expect? What will happen to them?
If no change, if the dosing schedule is not lowered or deleted, just get off the medication, it's just asking for trouble. Kidney function will continue to deteriorate, and they will have all kinds of kidney failure symptoms. And so as can have a gastrointestinal bleed for that sake, if they be blood thinners. So it is not optional. I would say it's mandatory that these drugs need to be monitored by at least 3 months follow-up visits and or also the blood test on a frequent basis.
All right. Now, another challenge I'm sure you encounter with senior citizens is declining mental status, maybe subtle changes in memory, or the other extreme, of course, would be dementia or Alzheimer's disease. So how do you deal with that challenge that somebody is at home and they may be on multiple medications and now they're having memory issues in terms of their ability to reliably take their medicines properly every day?
Well, normally I get involved patients' family members who bring them to my office, and or someone is looking after them. So a caretaker, a family member, the granddaughter, who is more savvy these days with technology, reviewing medicine with them, going over with them, talking to the pharmacy, talking to the caregiver. That helps to cut down, the patient unable to make decisions ourselves because of declining mental faculties, dementia, or memory loss. I think need to get somebody involved, which I normally do, or if we have none, we just call county to help us.
Sure. Now, are all patients that are older that have memory loss or dementia, is it always Alzheimer's, or do you ever find when you work them up there are other reasons for the memory loss or dementia?
Well, the declining mental function doesn't have to be necessarily the Alzheimer's disease. It can be short-lived, caused by a sepsis in the urine, which people
The
think is
sepsis meaning infection.
sepsis means infection. They have an occult urinary tract infection. They can have a subtle pneumonia. They can be having flu these days. And those just decline the mental function. They just crash. And as a result, sorting them out, doing a urine analysis or a chest x-ray, or whether they received the flu vaccine or not, or pneumococcal vaccine, they're up to date. I think this all amounts to a in-depth analysis of those patients, trying to keep them out of trouble.
Oh, sure.
We see all the time in ER setting at Holy Cross or admit patients. I mean, that is all we see, that is all I see, and it's very common, almost daily to day basis.
Now, you mentioned the theme of keeping your senior citizen patients out of trouble. So in terms of preventative care, I'll throw out a few vaccinations and share with our viewers what you think about it.
Yes, please.
Should a senior citizen get a flu shot every year?
Well, I recommend yes. They're high risk. We do lose a lot of patients per year in this country, and I think flu vaccination every year in month of September or October, when we start giving, they should be vaccinated. And the pneumococcal vaccine has own guidelines. They shall be vaccinated every 10 years.
That's for pneumonia.
That's for pneumonia.
Right.
Flu vaccine is every year for the seasonal flu.
Right.
Pneumococcal vaccine for the pneumococcal pneumonia
Yeah.
every 10 years, the booster dose.
Right. And what are your thoughts about the new shingles vaccine?
Well, I do have shingles vaccine prescribed, and I do recommend patients, because shingles can be very devastating illness. It is extremely when you have acute illness with shingle with rash, and the worst part is when they develop the shingle heal, they leave the neuropathic pain they call PHN, post-herpetic neuralgia, which is very painful.
That's inflamed nerves.
Inflamed nerve,
Right.
burnt out nerves.
Yeah.
That helps to give them some medication, and treating shingles in early phase, depending upon the age, again, we go down to kidney function again.
Right.
So whether it's valacyclovir 3 times a day versus 2 times a day, adjust the dose, and that really cuts back the morbidity and the complications of the shingles, herpes zoster, less post-herpetic neuralgia, less neuropathic pain. We see it very often.
Yes. So let's go to the other extreme of senior citizens. Happily, the other extreme is senior citizens that are aging very well. We all run into seniors that are still physically active, sexually active, etc. So a patient comes up to you and they're in their 70s and they want to do long distance running. How do you respond to them?
Well, I would like to thoroughly examine them, take their detailed history, look at their cardiovascular risk factors, whether they could have heart disease, whether they have underlying diabetes leading to kidney disease or coronary artery disease, the heart attack, they say. So if I know the risk factors for their impending coronary disease, heart attack, etc., they can get into. So before I give an exercise prescription, I want to make sure they couldn't have or they don't have coronary disease or heart disease. I like to screen them. I would like to get an echo, stress echo by cardiologist office, or make sure I do basic workup. They more than likely, they don't have heart disease before they shovel snow in a heavy snow day, and they can have a heart attack on the driveway and die.
All right.
But before I give any sexual enhancement drugs, I want to make sure their heart is good and clean. The vessels are clean.
Excellent summary.
Thank you.
We're going to pause briefly for a public service announcement. More with Dr. Suresh Gupta, an authority on geriatric medicine. We'll be right back.
150 over 90.
180 over 111.
160 over 110. I had a stroke.
This is what high blood pressure looks like. You might not feel its symptoms, but the results from a stroke are far from invisible or silent. If you've come off your treatment plan, get back on it, or talk with your doctor to create an exercise, diet, and medication plan that works for you. Go to loweryourhbp.org.
If I would have followed a treatment plan, I would not be in this situation.
We're back. My guest this evening is Dr. Suresh Gupta, a specialist in geriatric medicine, care for the elderly. Dr. Gupta, when we paused for the break, we were discussing some of the specific medical challenges of dealing with the elderly population. Now we're going to shift gears to discuss some of the social challenges for the elderly. So one troubling trend we're seeing locally and nationally is you hear stories about elder abuse, either physical abuse or psychological abuse. Share with our viewers some of the encounters you've had about this.
Well, geriatric elderly population is very vulnerable. They can't defend themselves, they can't do something, they get dementia, somebody can write their checks, somebody can just, take advantage of them. It's extremely very common, very vulnerable society. They need help. Usually family members kick in to help them, usually. And I've seen in my life, in 40 years practicing, usually family members are around and good. If they can't take care of themselves physically, they make financial arrangement to someone to take care of them as a caretaker to pay for them.
Yeah.
This is must. This is mandatory. They have to have that feature facility to be helped.
Are there any social agencies that are available either through the state or, for example, you mentioned Holy Cross Hospital, that can intervene when you sense there's elder abuse, either physical or psychological?
Well, county has hotline. We can call Montgomery County Adult Care Protective Services. They kick in, they assign a social worker to take a look into the matter. And it's our system, great system we have in this country, county and state, they take over. I mean, they want to protect our elderly. It could be your father, so I have to be concerned about. So if I find, see, or smell any neglect or any abuse of any kind, I think just pick the phone and report, and they deliver. They take care of it.
Excellent. What about malnutrition, where seniors are not getting adequate nutrition? How often do you encounter that?
Very common, very common. In elderly setting, which I see the patient with sicker problem in the hospital setting, where I admit, this is very common. I'm not saying the nursing home not doing a good job, but eventually with the course of time, whatever meals or diagnosis, problem, issues they have, they just wither away. They just start losing weight. They tend to use a coding word called PCM, protein calorie malnutrition. Their total protein drops down, their serum albumin goes down. I mean, it just need a whole lot to bring them back and know their ADA, American Diabetic Association calorie intake, and just not force, but make sure they can get that much calorie because they're declining health, which need to be addressed. And usually the system helps it. There is a system in place. If tapped, if asked for, they'll kick in.
You mentioned there may be malnutrition even in nursing home patients, but what about the senior citizen who lives at home, maybe lives at home alone? How often are you seeing malnutrition in that setting?
In my outpatient practice, I see this issue very often. The elderly people, they get certain money per month. They have to pay their rent. They have to pay their daily needs, whatever they are, and they get this much money to take care of their medicines. So it just really becomes medicine or food. Yeah. So as a result, they have to take medicine to live, or to not please the doctor, but to attend to their health. Yeah. So as a result, they have to compromise somewhere. They have to rob Paul to pay Peter. So they end up taking the medicines and compromise on their meals or regular meals, and they get in trouble with malnutrition, which is common. Unless some good family member children, they pitch in. This problem is also very common in outpatient practice life, what we see day to day.
Sure. Now, you mentioned the budgetary challenges some of our seniors face. How often are you seeing that, even in a wealthy county like Montgomery County? Do you see many seniors who find that they haven't adequately saved for retirement and that Social Security is not enough to support them?
Well, as we all know, this is Social Security money, what people have saved, it is not enough because we are now living longer. Yeah. I mean, I've seen patients 107 years old. Mm-hmm. I mean, that they didn't project then that this much money is going to live for how long. Mm-hmm. Now that money is not enough. And ironically, it's a sad situation that the financial planning was not done appropriately, thinking how many years they're going to live for. And it's, since I'm 64 now, I'm trying to get into this scenario.
Sure.
I mean, I'm planning myself, so I need to know how much money you need to have to live. If I live 20 more years, how much money I need to have my current lifestyle.
Sure.
So that problem occurs and is very common. Is there's not enough money on the pot till the elderly people is going to live. This will not outlast till then.
Yeah. And also you mentioned medications. Unfortunately, we see these horrific headlines every year about the rising cost of pharmaceuticals and that Medicare may not cover it all. So are you finding patients are making that difficult choice between paying the rent or their medications or their food?
Well, medicines are very expensive. There's certain medication which they have to take, for example, a blood thinner, for we call them NOACs, called, say, Xarelto.
Right.
A patient I saw, I mean, just can't afford Xarelto. They say, no way I can afford Xarelto.
Yeah.
But that's what the patient needs. A antibiotic, there's some good broad-spectrum antibiotic, which patient needs. It's arm and leg, very expensive. Medicines are very expensive. I mean, I don't think you want to buy off the internet, but if the Medicare benefits or the insurance benefits can't afford, it's patient has to pay. It's very hard to get around it.
Sure. So given these social challenges senior citizens are facing, the cost of pharmaceuticals, declining health, etc., do you find that there is a growing subset of your patient population that deal with anxiety and depression?
Very much. Anxiety, depression is very, very common in elderly population. They are lonely. When the holiday season comes, they get a sundowning effect.
Explain to our viewers what sundowning means.
I mean, as the dawn, afternoons come, they're home alone. They have nothing, and they just start feeling depressed.
Sure.
And they feel left out and alone. And elderly people get more sicker, and we see them more often during the holiday season.
Sure.
So just the loneliness effect. It's just it's elderly care is not just taking a sore throat 19 years old. There's a more complicated issues.
Sure. So somebody has depression, how do you decide what your intervention is going to be versus psychotherapy or giving antidepressants or seeing a psychiatrist? How do you sort through all that?
Well, I personally, at my practice, I would do a mini mental exam, see what issues are there. If some gentle some medicines can be introduced, which I can manage, I will introduce something. If I don't need to monitor by drug level, I will not. But if depression is so severe, my usual medication has not worked, I need help, then I go and find a psychotherapist or a professional psychiatrist, MD, and seek out help again from county government, which has a lot of support system for this program, our mental health program to the Montgomery County.
Do you find that the county is providing social programs? I mean, there are a number of senior citizen centers throughout Montgomery County. Have they been useful resources for you?
They are very much resources useful. As an outpatient, and we refer patient, we seek out their help all the time.
Yeah. And they offer social programs, activities, etc.
Very much so.
Yeah. Unfortunately, do you find that with the subset of seniors that are depressed, that there's an incidence of suicide?
Very, very common. I mean, there is an association, part of the Montgomery County AAHI, Asian American Health Initiative,
Yes.
under which also I'm a part of it because we do some grant writing and the mental illness, mental health issues, not only our general American population, we find depression and suicide very common in Asians and other ethnic groups which in Montgomery County, as you know, but 1/3 of Montgomery County residents now are multi-ethnic.
Sure.
So we see that very common, and we have a program to address that and help those people.
I should point out that Perry Chen, who's the director
Chen, that's
of
exactly
the Asian
true.
American Health Initiative, has been a guest on this show twice.
Yeah, Perry Chen, we work with him. I work
Yeah,
with him.
yeah.
We have a Dr. Sam Mukherjee, who was the chair of the AHI. Dr. Sam Mukherjee and myself, we work on mental health issues through a program we have Asian Community Services, Community Service, AICS, and we reach out to those people and do this program for county, honestly.
Very good, very good. Do you think there is a sense that in the Asian American community, senior citizens, there is a higher risk of depression compared to other ethnic groups?
Very much so. Just because we, the Asian American, we tend to not come out and speak about depression. It's like a social taboo.
Yeah.
As a result, they don't come out, but we are encouraging, reaching out to those in many programs we ourselves do, and trying to count through the county. We have started a mental health program for Asian Americans in Montgomery County through the AHI with Perijan you mentioned.
Very
Yes,
interesting.
very much.
Let's shift gears to discuss some of the evolution of Medicare in this country. Of course, Medicare is a social program that was first initiated by President Johnson in 1965, and it's been a very big success. But now, because of cost containment pressures, they're trying to develop different types of Medicare. One general category is Medicare Advantage, which is offered by United Healthcare, Johns Hopkins, etc. So tell our viewers the pluses and minuses of conventional Medicare versus these Medicare Advantage programs.
Well, in my opinion, Medicare insurance as is, if a patient has, the person can go to any physician, any multi-specialty group, any hospital, there's no restriction. But if one person takes Medicare Advantage, say Aetna, say United Healthcare, say Kaiser, whatever insurance they take, those Medicare Advantage groups, they have their own provider physicians where they can go to. If a patient needs an MRI, they're going to do an X-ray, they don't do an MRI. So that you lose that benefit of freedom which a patient has with pure Medicare. So I personally feel a Medicare Advantage is not good for a person. He or she will end up losing his own physician. He will not be able to, because if I do not take Aetna Advantage, Medicare Advantage, I can't see that patient.
So it really limits their choice.
So a person 30 years old coming to me just has to find a new doctor.
Yeah.
So as a result, I am not selling anybody, but I would recommend Medicare Advantage for a elderly patient, sicker patient with medical problem. Is not a good option to choose, switch from Medicare to Medicare Advantage. That's my opinion.
All right. We've run out of time, so if our viewers have any questions about geriatric medicine, how can they reach you, Dr. Gupta?
Well, my name is Dr. Suresh Gupta. I practice in Silver Spring, Maryland, next to Holy Cross of Georgia Avenue. My number to reach would be my office line, 301-681-5922. And if you still want to reach out to me, the children of those Medicare people, elderly people, check me on Facebook under Suresh K. Gupta, MD.
Thank you for joining us on House Call.
Pleasure.
My thanks to Dr. Gupta for a terrific interview. My thanks to the studio team here. And most important, thanks to you, the viewer, for welcoming us into your home. Tell us how we're doing. You can reach me at my practice website, montgomerygastro.com. As for our next show, Dr. Robert Stillman, an authority on infertility, will be reviewing this very important topic. It's going to be a wonderful show. See you then next time for another edition of House Call. Good evening.